today, and we'll share with you later where you can access this recording, as well as some additional resources and materials that I'm sure will come up. As far as the conversation, we really do hope that it is participatory. Our panelists are here to guide the conversation and guide the discussion, sharing their insights and knowledge. But coming here today, you all are experts, and we really do hope that you bring that into the space and conversation. So for the webinar today, this is really launching the GPP Essentials document, which is the essentials, principles, and practices for GPP compliance, engaging stakeholders in biomedical research during the COVID-19 pandemic. And, AVAC really put together this toolkit, not just for stakeholder engagement practitioners, but really researchers, clinical trialists, bioethicists, and even advocates, really thinking about how you can get involved and really accelerate this research and keep it moving forward, with the idea that stakeholders and community are essential part of that research. And at the same time, as we released this toolkit, there was a wonderful paper in Nature that was actually published by Barthalomew Wilson and his group from the NIH, and so we thought that this was a really excellent time to bring not just Bartholomew with us, but also Miliswa Magongo and Danielle Campbell together to have a real conversation about how these principles and practices have been used within the COVID-19 space, and how they can continue to be used, not just in this pandemic, but in all research moving forward. And so we're going to start with a presentation actually from Bartholomew Wilson. And so Bartholomew is on the Social and Mobilization and Communication Manager of the Partnership for Research on Ebola and Virus in Liberia, a clinical research program between the government of Liberia and the United States. Bartholomew supervised the advocacy, communication, and community engagement activities in the ring vaccination response efforts during the 2015-2016 sporadic Ebola virus disease outbreak in Liberia. And prior to joining Prevail, he volunteered with the case manager unit of the National Ebola Response Program at the Ministry of Health, supporting the areas of case investigation, case management, and contact tracing. And he'll be walking us through the paper that, like I mentioned, he published around the importance of good participatory practice in the Ebola and COVID response, and we'll be really sharing and setting a framework for the larger conversation that we hope to have today. So over to you, Bartholomew.
Thank you, Jessica. Thank you so much. Good morning, good afternoon, depending on where you are. Thanks for the introduction, Jessica. I think this is going to be a very interesting conversation, and I'm happy to be invited. We will try to give you, a summary, a contextual summary of the paper that was published. And we hope that will set the foundation for some of the conversations and discussions that will happen anytime soon. So good participatory practices, in our paper, we argue that beyond recruitment, they kind of support the impact of research in a pandemic. And so we will try to validate that assertion in the next 10 minutes. So just a brief outline of what we hope to cover. We'll talk about community engagement, and the impact in clinical trials and why we engage communities. And then we'll look at the Prevail strategies that were used during the Ebola outbreak. So most of the time when people talk about community engagement in clinical trials, mostly you hear about recruitment and retention. The focus is mostly around recruitment and retention. But there is a fundamental reasoning behind why you engage communities in the first place. And that reasoning is because community engagement helps to build trust. And trust is a crucial requirement that can only be fulfilled through effective community engagement. Trust is necessary not just for clinical trials, but also in terms of how the outcomes and results of those trials are related back to the community and how they impact the lives of people who participate or who are impacted by research. So community engagement provides that platform where local voices are heard and where people are able to express their fears and concern about a trial. And also they share their views and we make sure that their views are heard, not just the fact that they're sharing their views, but those views are taken into consideration throughout the course of the trial. And this is a very important component of good participatory practices. So how do you build trust? Now, it is a long, ongoing process. Trust is a precondition for treatment and vaccine uptake. We always agree to that. When people, refuse to take vaccines or refuse to accept certain treatments, it is because of many factors, but mostly because there is a lack of trust or there's some level of suspicion, that come out of the conduct of these trials. So trust is attained, we say trust is attained through bidirectional communication. And what we mean by bidirectional communication is exactly what is described in the community engagement process. Researchers get to share information with communities, and the community also get to provide their own perspectives and concerns to researchers. So it is a bidirectional communication. And it is important to remember that the absence of trust in research and researchers does not only disrupt and delay the conduct of study, but it also negatively impacts, public acceptability and uptake of research results. For example, new treatments and vaccines. And there's an example of this in the US right now. So we have the monoclonal antibody trial that was conducted. The results are very interesting, very encouraging. But the unfortunate thing is that the utilization of these interventions, are not aligning with what the results look like. So there's an underutilization of these outcomes. And this is primarily because communities and other stakeholders were not properly engaged during the development of these interventions. So when we talk about bidirectional communication, this is how it looks. And you have the stakeholders. Of course, stakeholders are all those who, are impacted by the research or who could impact the research in one way or the other. And we argue that it's an ongoing process. It takes time. It requires resources, including skills and local expertise, as well as trusted voices, because it's not just about what you're communicating. It's also about who is involved in that communication process, who is providing the information. It has to be people who are trusted, okay, locally, people who can be relied on in terms of transparency and accountability. The goal of community engagement and bidirectional communication should not only be about recruitment. It should be way above recruitment. It should be about sustainable partnership with communities, partnership with stakeholders. Next slide, please. And so this is how we describe it. You have 3 levels of engagement. You have engagement during study designs. You have engagement during study implementation, and you have engagement during study closure. So most of the time, people are right in the middle, study implementation. This is where you see most of the engagements happening. Unfortunately, this level of engagement does not really benefit the community. It's more about the researchers. Communities are mostly benefited when they are engaged before study implementation, doing the design of the protocol. Okay, this is where you get their voices, their concerns. This is where you get their opinions. And it helps to improve study and recruitment design, right? So you also have messages that are locally acceptable and culturally appropriate. So those kind of feedback that you get doing this level is way beyond just recruitment. The other stage of engagement that is very important is when the study has closed and you need to communicate the result. Okay, you provide important explanation of results because that will facilitate the acceptance of the trial's outcome. You also try to improve community health through research finding. Of course, that is what we do when we conduct research. We want to improve community health, okay, through the findings that we generate from the research. And so this is an opportunity to build greater trust and respect between researchers and the community for future collaboration. Because at the end of the day, tomorrow you might come back, you want to conduct another study, and the level of engagement that you built over the time could help to facilitate the other studies that will come in subsequent time. So what have we learned from Preview? In 2015, we started a double-blinded placebo-controlled trial in Liberia. The local context at the time was that the environment was so difficult. Civil liberties were restricted. We had increased social vulnerability. There were lack of trust in officials and health authority. A lot of people did not know about research. Okay, not many studies have been conducted prior to 2015 in Liberia. So this was the environment. This was the situation at the time. And so, next slide, please. When Prevail study started, our objective for having a social mobilization and a community engagement strategy was to identify the social and cultural norms. We wanted to build sustainable partnership. And so the way we started this was to first of all, bring on board people from both sides, the US and the Liberian side. So we have a partnership. The NIH provides the funding for our studies, and then you have Liberian experts from the academic community, the scientific, including the local communities. They are part of the partnership. So we built that partnership and we established research capacity in Liberia before we went on to begin to do what we call the 4 pillars of our SMC. And that is the advocacy, the community engagement, the communication, and the M&E component. So the SMC roadmap was developed, and that roadmap included what we call community mapping. So in the community mapping, we identify the major stakeholders, formal or informal authorities, including gatekeepers and influencers. And then we also conducted the listening session. Listening session basically having small meetings and focus group discussions to understand community knowledge and attitudes, but also the perception and beliefs, that were associated with Ebola and the Ebola vaccine trial. So we identified the potential barriers and what the facilitators were through the listening sessions. During the advocacy stage of our engagement, we solicited political will and built support for clinical research. And this was done basically with officials, whether elected or political leaders, community-based organizations, and the different stakeholders. Then the community engagement, which was to promote among researchers cultural sensitivity and understanding of community perception and concerns. Then we went on to communication, building trust and sustainable partnership with the media executive, because the media has a very crucial role to play in disseminating information regarding the study. Okay, so building that level of research literacy and creating the awareness was very important in communication. Next slide. For the M&E component, we had to ensure that community engagement was evidence-based. We measure the impact of community engagement and communication, and then we determine which of the strategies or methods were more appropriate. Okay, at the end of the day, we had to document the impact of community engagement on the understanding of clinical research. Next slide. So part of this whole process was community empowerment, because when you empower the community, what it does is that it makes them to see themselves as partners and owners of the research. So we did not just want volunteers from the community to participate in research. We wanted them to see it as a community-based project where they could take ownership. So we empowered them. We recruited participant trackers. And this was modeled after the contact tracers, okay? So during the Ebola outbreak, we had contact tracers who were following contacts and contact of contacts. So those people play a cardinal role in the Ebola response. So we model our structure around that, and we had the community trackers recruited, and they were responsible to follow participants and make sure that they come for the study visit, and the participants build a relationship with them so they could share, their fears and concerns to the trackers, and the trackers will bring that information to the research team and will make sure those concerns are addressed. So it was a kind of, liaison role that the trackers play. So this is the big question. What happens when communities are not engaged in clinical trials? Now, these are some of the things that we've learned from Prevail. We realized that they feel research upon rather than partners in the process. Okay, the volunteers feel used. There's an increase in suspicion and misconception. There's a lack of trust in research. And then the benefits to community are either non-existent or they are not clearly understood. All of this results in the unlikelihood that the trial's findings are translated into actions and changes that benefit the community. Okay, so this is what we've realized from Prevail trial in Liberia. Some of the other lessons that we have learned is that trust within research community can facilitate easy community entry. It leads to a rapid change of public perception and misconception. Now, what needs to happen is that you need to conduct formative research to inform clinical trials. But it is quite clear that during a pandemic or epidemic, you may not have the luxury of time because people do not even anticipate that this is going to happen, right? So you may not be able to conduct the formative research. But what is important is you need to conduct some level of listening with the communities to try to understand, their fears, their concerns. What are the factors, the traditional and local factors to consider? So this is what we did. We did not conduct formative research, but we conducted some level of listening and trying to hear those concerns. Researchers should also be sensitive to local and cultural requirements for community engagement. And it is always important that scientific standards work within the culture and not against it. So it has to be a win-win situation. Thank you. So this is what we wanted to share. And if there are any questions or comments, we'll be happy to take them.
Great. Thank you so much, Bartholomew. That's such a wonderful segue. And before we maybe get into it, I do want to just introduce formally our other two panelists. So we'll start from the West Coast of the US and move towards the East into Africa. But just starting with Danielle Campbell, who has joined us this morning from Los Angeles, California. She works at UCLA as a member of the faculty in the Department of Preventative and Social Medicine at Charles R. Drew University of Medicine and Science. Danielle is a member of AVAX PX WAR US program. She is a member of the ACTG Community Scientific Subcommittee. She's a member of the COVID Advocates Advisory Board. She's a member of the Martin Delaney Collaboratory Community Advisory Board, and has just really been a champion of women's prevention and really health system strengthening for as long as I've known her, for quite some time. And we're just really honored to have her here and sharing her perspectives this morning. We're also joined by Miliswa Magongo from the WITS RHI in South Africa. Miliswa joins us from Johannesburg this afternoon for her, and is really bringing her expertise leading the Good Participatory Practice program at WITS RHI. She's been working in community engagement for over 5 years now, and as I said, doesn't just play a strategic role in thinking about how WITS RHI coordinates and conducts GPP, but also really thinking about how, again, to strengthen health systems widely, and brings her passion into this conversation this morning as well. So welcome to you ladies as well. And I'm going to just start off with a follow-up to you, Bartholomew. You mentioned trust a lot in both the presentation and the paper, but I think another piece that you really brought into this conversation is the idea of creating those systems of engagement that can really be utilized, and in particular, kind of talking about those health trackers. Can you talk a little bit about how those, or explain a little bit more about this system of bringing in that lessons from public health in developing those systems of trackers? How did that idea actually come into play? Where did you sort of get that initial thought, and how was that infrastructure built?
Right. So when we started having the pre-engagement meetings with community leaders and talking to key informants, so there's one thing that they told us. They're like, if you have to be successful in this research, you need to get the community involved. Okay, and we were like, okay, now how do we do that? Like, we know nothing about this. We consider ourselves to be completely ignorant to this. So you tell us. And they said to us, the reason why Liberia is becoming more successful in the Ebola response is because of the role that community play in terms of contact tracing. So we believe that you should get the Ebola task force involved in a way that they can also help you to track those people that will be participating in the trial. You may not know where they live. You may not be able to reach out to them. There's huge level of stigma in the community. But if you have people who are from those communities who are respected, who they can relate to, it makes it easier for them to track your participants and to inform your participants of when the next visit, and to let them to come for retention. And that was a great idea. So we bought that, and we asked the community leaders to recommend people who could serve as participant trackers. So that's how the idea came about.
Great. And I'm going to pick up on that piece, but just as a little housekeeping note, there's already questions coming into the question and answer box. We do really encourage that participation during the trial. We will begin to get to them, but I do want to continue this thread of building an infrastructure. And Bartholomew, you picked up on, you mentioned this piece around the way communities were involved and, throughout the response. And I want to pick up on that with you, Danielle. Actually, as I mentioned, you're a member of the COVID Advocate Advisory Board, which is a new global mechanism that was created to really have community play a role and a voice in this research process. So can you talk a little bit about both the CAB as, what it is, and then a little bit about the experience as a member?
Thanks, Jess, and thank you again for extending the invitation to be part of such a dynamic dialogue today. So the CAB really, it is what it is. It's this monstrous global body of advocates who are really concerned about some of the interplay that we see in health inequities around COVID. And so that includes social justice, that includes access to vaccines, that includes access to treatment, that includes, the dynamic and rapid commencement of this research infrastructure around COVID, right? We want to ensure that there's a community presence from the onset as we move forward with charting the COVID-19 global pandemic. And the CAB meets once a month on the third Thursday, and we are wrangled and organized by our administrator extraordinaire, as I call her, Leah. And she's fabulous and she's everything. And she takes us through some of the emotional, scientific, and social considerations that community often experiences as we organize and mobilize around this health issue. So it's been a great way for me as an advocate, as a science advocate and a social justice researcher, to be a part of some of these global and multinational conversations and having the ability to bring those dialogues locally. So it really takes, you know, this abstract and collective fight for COVID, and it brings it to a space of consensus, and you can just really be amongst other advocates to share ideas and thoughts. Yeah.
Great, and the CAB I know has really played an integral role in thinking through some of these early phase vaccine studies as they were rolling out, you know, now a year ago, really having this dialogue, yeah. And we'll pick up on that thread, but you were also, Danielle, just led me to think of a question I want to make sure I bring to Miliswa right away, which is just this idea of research literacy, and how you were saying that the CAB is really highly a research literate group. And I think something that the pandemic has shown us, or at least has highlighted for me, is that perhaps we've taken research literacy for granted, and that the speed of which the pandemic has happened has really brought scientific literacy and the understanding of the research process to the forefront, and the importance of sort of getting that knowledge out. So Miliswa, you know, there's been some confusion in South Africa around the research process, and I wonder if you can talk a little bit about, you know, how has VITS RHI been thinking about addressing sort of some of these issues and maybe gaps in knowledge around the research process?
Hi, Jess. So thank you so much as well for inviting me to be a part of such a great discussion. So part of what we've done, or what we've been doing since COVID started, is to, first of all, tap into the long-time partnerships that we already have with the community. So when COVID started and we had some trials that were around COVID-19 that were about to start, in South Africa at that time, there were some protests that were happening where advocates, and in particular, had particular issues such as maybe lack of enough community engagement that was happening at that time. And we took that proactive approach of, even before we started implementing our trials, to reach out not only to our local CAB, which was the formal structure that we have, but to also reach out to the advocates that were in the forefront of those discussions and protests, and have a conversation with them about some of the issues that they were raising around lack of community engagement, and finding out how best we could engage with people on the ground, etc. And one of the outcomes of those discussions was we were invited to some platforms, webinars, etc., where our scientists would share their expertise around research, the process around research, what it means to conduct trials in such an environment. So it was so we basically used all the channels that we could. So it was the stakeholders. We used webinars to reach out and educate. We used media as well, TV and radio, to get on there and not only talk about the trials that we were conducting or planning, but also to educate our communities and stakeholders about the science around clinical trials, etc. And of course, using social media, because we know at that time there was also there was the start of the lockdown, so there was also the concerns around around how to reach our stakeholders, around how to reach community members and provide sufficient education for them. So we used social media as well a lot to provide research literacy. So that's just about some of the strategies that we've been using and that we continue to use to promote research literacy in the community.
Great, thank you, Miliswa. And I think you really highlight, Bartholomew's point from earlier about the real importance of having this structure in place, because trust is built over time, but not just trust, but also these avenues to communicate and to disseminate information, not just when it comes to post-trial results, but also the really critical information needed to both get feedback for this bidirectional conversation, but also just to really allow people to be able to participate in the conversation and sort of understand when this speed is happening so quickly. So there was a really, this is going to be a question for everybody, but this idea that, Bartholomew, you talked about scientific standards and having worked with the community. I'd really love to have this conversation with all three of you, but I'm going to first hand it over to you, Bartholomew. Talk a little bit about the importance of community engaged and co-created research being part of being part of this pandemic response. So Bartholomew, can you maybe just talk a little bit about the importance of co-created research?
Right. Yeah, I see myself as an advocate of community-based participatory research. I think it's very important because oftentimes we researchers go into a community and we think that we know what the problems are, we know what the priorities are, so we come with our own research question without first of all hearing from community members what their priorities are, what the problems are, and how those can be resolved. I think that is very important going forward. Now, the challenge is most of the time, people who fund these research projects already have set guidelines or standard of what kind of research they can sponsor. And so even in a pandemic situation, it's even more complicated because at that point, it's more about, interventions, it's about therapeutic trials or vaccines. Even social science research does not get that kind of support financially to be able to happen. So this is where the challenge is. I will agree that it's important for community to have a say in what kind of research they think will be appropriate for them and that they will want to support. But I'm not sure if the resources will be available to be able to follow up with those suggestions from the community. I think most of the time it's always the opposite, where the researchers already have funding available for a particular research question that they want to answer.
I'm going to open it up to Danielle or Miliswa. I don't know if you have points to jump in.
Of course, I'd echo Bartholomew's points here. I think, right, researchers often have these like super illuminous ideas, and I think that's great. But I think, part of what we see in the prevention space is that innovation doesn't always drive utilization. So the target users or the end users, the population that could potentially stand to benefit from an innovation in my area of expertise, HIV prevention, they're not always represented, right? Those individuals who are most impacted by HIV aren't always represented in populations of users of innovation. And we always wonder why. And part of what I point to in the discourse with pharmaceutical companies or other systems of power, right? Systems of privilege or systems that sometimes oppress individuals at and prevent them from actively benefiting from some of these innovations, right? Without community input, without that involvement, that advanced involvement of individuals who could stand to benefit from use of these innovative technologies, they'll fall flat and rates of utilization will be super low. And that's one of the challenges that we've been sort of pressing against. There's no way around community and meaningful involvement of community as you roll out, you know, these studies and as you consider innovation in anything, right? Community involvement, the voice of the end user is critical, and I can't overstate that enough.
Absolutely, and I think, you know, I'm going to steal a phrase from actually Bartholomew, who says, in short, beginning with the end of the pandemic in mind, one must begin with GPP. And really to think about communities up front is really a critical piece, but not just for the design of the research question, but also really thinking about how to effectively engage community around the design of the protocol. And thinking about the end, and Danielle, to pick up on this point about the need for community to be involved because of uptake, you know, that comes also the recruitment and retention as well, to make sure that we have a diverse set of populations being represented in the trial. So, you know, somebody asked very practically, you know, how can communities and community engagement managers promote more access into the design stage of clinical research, particularly around, I think, COVID prevention or COVID vaccine and treatment trials?
I think that's a really great question, right? So I operate in the space that community knows best, right? So if you're gonna diffuse innovations into communities, you have to first start with those individuals who are key stakeholders, gatekeepers, right? They'll give you the best insight as to what strategies will be most useful in engaging community. So you have to pull from within community to engage community, because those individuals from within community best understand their local context. And that's one of the direct bridges of applicability we see between HIV and COVID. These are hard lessons, you know, 40 years into this epidemic, and it has such seamless translatability to what we see in COVID. And I'm hoping that as we move forward in engaging communities in all aspects of research, that is a central tenet to the discourse, right? You must work within frameworks of community to understand and engage the local context. And, you know, the output is much more favorable, right? You have communities like what Bartholomew talked about. The needle will move in terms of amelioration in public health when you have that direct tie into community. And that's a great example that we saw presented here today.
And I'm going to get to the global structure that actually you sit on. But before we turn to that, Miliswa, as this RHI is really a gold standard of engagement and setting these infrastructures in place for community input, I'm wondering if you could just expand a little bit about how this RHI maybe has put that into place. And again, the specific question is on, you know, what specific role can community play in the design process?
Okay, so some of the structures that we have in place, formal structures, are we have the community advisory boards, which are the formal structures. It's one of the formal structures that we have, which gives us access to the community on the ground. And then we also have programs such as the GPP leadership course, which enables us to create, if I may put it that way, or build GPP champions or GPP leaders, people who after being our GPP champions, they are able to go back to their communities and in different parts of Africa and advocate for good participatory practice in clinical trials. So that's some of, in addition to what I said earlier, so that's some of the formal structures that we have that have enabled us to engage well or meaningfully with our communities.
Great. And this idea of building champions, I think is such an important role. And again, you know, something that has really come out in the pandemic for me, you know, there has been such movement on the idea of engagement of global stakeholders and stakeholder advisory bodies and coordination that has really come out of the speed of this. You know, people are thinking about the end at the beginning, and there has been structures like, you know, the CAB that I mentioned that Danielle is on, to really create formal mechanisms for community input. And there is a beautiful comment about this idea of, you know, there's really a challenge in community engagements and protocols because you need to start again. And so my question for the panel, and I'm going to start with Danielle and then move to Bartholomew, but just to say, how do we, or what are your thoughts on how that we can continue to sustain the momentum and coordination that we've established during the COVID pandemic and continue to utilize that, to add that engagement of that global coordination and engagement into some of the HIV prevention, TB treatment, and vaccine work that's happening to speed up the introduction and accessibility of other products in the pipeline? How do we take these lessons learned from COVID and really apply that to the strong engagement programs that are being built up, you know, at that local level throughout other research? And so Danielle, I'm going to start with you.
Thanks, Jess. I think that's a really awesome question. So a few things come to mind. I think documenting the movement is a great way, right? GPP is written and it's easily accessible, right? So folks can, you know, click a website, find the principles, and then take them back to their respective networks and contexts for reference. One of the things that I'm super excited to see on the CAB is we're encapsulating our efforts. So we're writing them down, we're documenting our history in real time, and we're sharing that history both locally and globally. And our CAB is made up of a global representation of key stakeholders, not only in HIV, but in TB and other disease states. And so by us documenting our history and some of the efforts that have come from it and being engaged with key stakeholders in a multitude of disease states, I think that's the best way to ensure diffusion of innovation across disease states as we move beyond, hopefully, our connection to COVID. So it's important for us to tell the story and document our movement. And as we document our movement, take care to engage key stakeholders from around the world, from diverse backgrounds, groups, localities, religion, sex, gender, you name it. If we have that diversity there, if we tell our story both locally and globally, and if we document it, right, it's easily accessible and translatable to other movements within not only HIV, but other disease states. So I think that that's been beneficial to us as we become this, hopefully, as we become this example of when GPP goes right, when things happen as they should, as an example to others who may want to mobilize in the future, not around COVID.
Thank you, Danielle. I mean, that is such an important piece. And obviously the Essentials document does kind of lay out some of these steps around documentation, just as, you know, as outlined in GPP. But I think that that really hammers it home, this idea that, you know, taking this global structure, learning from it, and perhaps figuring out ways to sustain and continue this, and Miliswa, to bring in those champions that can really be those dot connectors. So between, you know, thinking about what's happening on the ground in a 5 to 7 year, prevention trial, things that are sort of going on for longer, but can look ahead, can kind of step out of that day-to-day engagement and really think about this whole picture, which is obviously what the CAB has been doing around COVID, really looking at these issues holistically. But Bartholomew, I want to just pivot to you and ask sort of the same question: is, taking the lessons learned from Prevail and others in COVID, how can we utilize that and take that back into non-pandemic research and carry those lessons forward?
Well, and I agree with Danielle on, everything. And let me say also, GPP, the need for GPP has been proven times and times again, starting from HIV, the early days of HIV, the Ebola outbreak in West Africa, re-emphasized that need. And COVID now even makes it stronger for GPP to be more than just a matter of choice or just something that is necessary. But I think we have to get to the point where GPP becomes mandatory, just like GCP. And I think this is where we are. This is where we are headed. Sorry. So making the case, documenting the lessons learned, and getting to a point where the ethics committee, for example, can start to enforce the implementation of GPP in trial design. I think this is going to help a whole lot, because even in Liberia, with the lessons that we have learned and with our own experience, I know sometimes I get into real heated argument with some of our senior researchers who think that implementing a GPP roadmap is a waste of time, is a waste of resources, and sometimes they get frustrating, and you have to try to get to convince people why we need to do this. So the message keeps going across. People are listening and people are beginning to buy into it. But I think we need more than just convincing people that this is necessary. We need to get to a point where it becomes a requirement and people have to go by it. So one of the things we're doing now in Prevail is that we have this training also for GPP. So we're developing a training module, and we're going to train out of our researchers, including out of the PIs and people who are working on the different protocols on GPP. And we think that will help to get people to understand why this is important. Yeah, but until it becomes a requirement, I think we'll still have some challenges. But the most important thing to remember is this is something that should happen even before a pandemic, hits. Because in the time of a pandemic or an epidemic, you may not have the time to go through all of the different and various steps of engaging the communities. Whereas if there is some level of engagement that was happening and some collaboration and partnership being established, it paves the way for more research that will come in during a pandemic situation. So I say at the end of the pandemic, when all things are normal, it is the best time to start doing GPP and preparing for the next pandemic.
Great point, Bartholomew.
Yeah. Please go ahead, Miliswa.
Oh, yes. No, I totally agree with my colleagues. And in addition to that, one of the things that we've seen that has come out of the COVID-19 response globally is how resources have been pulled in together into engagement efforts, into literally every effort in trying to make sure that we develop a vaccine at a rapid speed, etc. So I think going forward, if there can also be that drive or that commitment from the different from the sponsors, etc., to make sure that there are enough resources that are committed into community engagement work. I think that can help assist in making sure that in institutions, GPP is institutionalized, and we bring about better change in future trials or better engagement.
I mean, all phenomenal points, really well said, everyone. And I think, you know, COVID has really, or this pandemic has really kind of illustrated that these issues aren't black and white, and that they really are all connected. And so thinking about things like protocol design, having, you know, ensuring that there's equity and access post-trial to treatment or vaccines if they were proven effective isn't just crucial because it is the ethically right thing to do, but also because there's regulatory implications for data follow-up, and that this type of work has shown that, like to Miliswa's point, stakeholders can really come together very quickly and efficiently to think through all of these issues. So there's a few questions just remaining, and I know just a few minutes, but there was a really important point, which is that, you know, I think that we've really talked about this bidirectionality and this need for a two-way street of engagement and conversation and education. What are some of the mechanisms that have really been put in place to establish right up front the need to educate researchers around community needs regarding the new realities of the pandemic? So maybe, Miliswa, you can walk us through, you know, how do you ensure the feedback from community members to researchers through the same channels that you sort of mentioned? Is it social media? Is it others? So that researchers are also educated regarding the new realities communities are experiencing through the pandemic.
Yeah, thank you, Jess. So one of the nice things about the sort of virtual world that we now live in, and with the channels, the added channels of communications that we now have, such as social media, is that when you conduct engagement there, for instance, if you're doing a live session there as a researcher, or you are doing, you are posting on your social media page, then it's platforms where people in the community can, at that moment, be able to ask the hard questions, be able to also, as my colleague said here on the question, they can also have the opportunity to also educate the researchers on the realities on the ground. So it's participatory, if I might put it that way. Even the webinars that we hold, like the one we are holding now, it's spaces where the participants or everyone who is a part of the webinar has the opportunity to also engage with us. And if we have an expert or a researcher in the room, they are able to be engaged, ask the hard questions, educated as well about the realities. So so that I think so that has been the way in which our researchers have been able to learn more about what is happening in the community. And of course, this continuous engagement and partnership with all the stakeholders that we work with, whether it's the local CAPs that we have or the advocates who are also working in our communities to promote research, being available to be invited in their spaces where you don't just get to present about your study, but you get grilled or you get asked, you get educated. So that's just availing yourselves to be a part of those structures. So that is how I believe we have also got to learn about the realities on the ground through this these social media, these media channels.
I mean, that's so important and really leads back, Melissa, to this idea of building trust and being able to, not just go to the community for a specific trial or at a specific time, but to build these deep roots and the role that GPP can play in that. So I want to give everybody on the panel just some final thoughts. So Bartholomew, I'll start with you and then move to Danielle and then finally Miliswa. Just any final thoughts that you have around, again, what are some of the lessons learned around GPP, and or what are the practical ways that advocates and the community engagement professionals on the call today can begin to utilize GPP in their practices?
Yeah, so I think my colleague talked about that earlier on. It's important to have the resources, you need, because everything is about funding also, so we need to start mobilizing resources for GPP. And we also need to start building more relationships with communities, either through community advisory boards. And now the community advisory board is a great way to get community input into the design. I think someone asked that question earlier on. How do you get input during the design of a trial from the community? Community input comes through the advisory board. Once you have advisory board or advisory committee set up, they provide input into the design of the study, and some of the inputs are not basically scientific. They have more to do with operationalizing the protocol and taking into consideration the local and cultural perspectives. So I think that's a great way to engage communities and solicit their input. Another thing that we have to consider is that GPP is a process. It is an ongoing process that should not only be centered around recruitment, because the whole point about GPP is not to get people to join your study. It's more about getting people to trust, the study and to be able to accept the outcome of the study, which is what COVID is teaching us. This is the lesson that we are learning from COVID. Thousands of COVID vaccines arrived in Liberia, my country. And we just did some view sampling, and you realize that over 85% of people in the population are not even inclined to take any of those vaccines. Now, if people are not going to want to take COVID vaccines, it is a waste, because the huge resources that went into the development of the vaccines, okay? And so I think GPP would have helped to resolve some of these issues, because while we were thinking about developing a vaccine for COVID, we should have been conducting some kind of social science research around community perspectives, concerns. What are the barriers that could affect the acceptability of a COVID vaccine in Liberia? We should have thought about that. We should have started making some effort to understand the potential barriers or facilitators, so that at this point, we already know what they are and how to deal with them. But unfortunately, that did not happen. So I will say again, think about the end in mind while you conduct GPP.
Great. Thank you, Bartholomew. Danielle?
Bartholomew made a great point that I think we should use to carry us out, right? This whole process about GPP and conducting research really is built on trust. And trust is a principle of social justice. If communities don't trust you, no matter, the feat of innovation, they won't engage, even if it's in their potential best interests related to their health. So I think we should consider that as we move forward, right? Remember that investigators are people, that the research industrial complex is comprised of people with thoughts and sentiments and maybe their own preconceived notions about what may be best for communities. However, what we've learned across disease states and throughout time, since time was time, is that community knows best and they understand the local context, and that value added is worth respect and should be put on the same standard as those individuals from the academy. So if there's any hope that we are to move away from a top-down approach and a more sustainable approach of equity, health, rights, and justice, then we have to center those perspectives of community and key stakeholders moving forward.
Thank you. Miliswa?
Yeah, so in addition to what my colleagues have said, I think this concept of continuous engagement with the community, it's also very important. We shouldn't wait until we have another pandemic in order to promote research literacy, for instance, but this should be a conversation that we have continuously, because we all know that even when the pandemic started, the people who were in the forefront, for instance, to advocate for age and gender responsive approach to COVID-19, or to advocate for a human rights-based approach to COVID-19 research, were the people who were already in the forefront in advocating for these things, for HIV prevention efforts and research. So it was easy for them to take the baton and run with it and make sure that they continue with creating awareness in our communities. So so it's important that we continue to educate, we continue to create the GPP champions in our communities, so that when another pandemic, we hope there won't be another one, but when another one hits, our communities, we will be at a better position to welcome research and engage more with us. Thank you.
Great. Thank you so much, Miliswa, Danielle, and Bartholomew, for your time and your expertise. And I mean, you all just really hit the nail on the head. And you know, this pandemic is not over. Research continues, and the idea that we will continue to involve community is so critical. The speed is really an opportunity to get more seats at the table, to expand the table, to expand access to think about this research, because the problems are going to be tricky. You know, the dealing with inequities, dealing with the ideas of prevention and populations, getting more voices will only make the research stronger. The GPP Essentials document is just one of many resources, but an important tool to think about how you can utilize GPP in this work. And I do realize that there are other questions, but we are at the top of the hour. So I do really encourage everyone to connect with the conversations that are ongoing on Engage. You will be able to find this recording on the Engage platform, the website listed here, as well as avec.org and the COVID CAB. And we will be listing out resources in places to connect following this webinar. I want to thank you all so much for your time and for your engagement in the conversation today. And really, again, thank you so much, Danielle, Bartholomew, and Miliswa, for your real expertise and willingness to share with us. So thank you all, and we will look forward to continuing the conversation on Engage. Have a great day, everyone.
Thanks, Jess.
Thank you.
Have a good day.